stalwarts in the field who have spoken about so many things. So what I'm going to do is, I think climate change is not only about air pollution and heat, but it does cause many other things. I'm going to briefly touch upon air pollution and heat-related deaths and what we have done in that area, but also look at some of the other areas such as flood, food systems, and so on. So in terms of climate change, what do we know? Changes in temperature and other meteorological changes impact cardiovascular disease mortality. This is kind of well known, and it is the leading cause of premature death. More than 62% or nearly two-thirds of the deaths have been attributed to climate change. More than two-thirds of the deaths attributed to climate change were from cardiovascular diseases. There's a linkage between temperature fluctuations, both cold and hot, and cardiovascular mortality, with higher risk during extremes of weather, and a total of around 100,000 deaths have been attributed to this worldwide in the year 2019. So it's estimated that every 1 degree centigrade increase in temperature increases cardiovascular mortality by around 2%. So that's a kind of figure that is put out. There are vulnerable populations, and there are three groups of vulnerable population are affected by extreme heat, and these are older people, people with pre-existing conditions, and people with comorbidities, and the socioeconomically deprived groups. So other effects of climate change, as I said, beyond the temperature, includes floods, droughts, power outages, contributing to increased cardiovascular disease burden and cardiovascular disease complications. So what are the indirect effects of and vulnerability of climate change on cardiovascular disease? So it goes through multiple complex pathways, and there are other social determinants such as poverty and unemployment, access to healthy food, access to health care, and several other things contribute to the vulnerability. And the disruptions could be physical, biological, and through ecological systems. And as was pointed out very elegantly earlier, there is interaction. There's multiple interactions of various climate change factors. Like for example, in terms of health itself, cardiovascular disease may occur in isolation because of several risk factors that we talk about, but there is a syndemicity, by which I mean many patients of cardiovascular disease die of infections, and infections increase because of climate change. So there is that interlinkage, there is that interaction, and we need to be cognizant of that. And there is also threat to mental health and interactions. And specifically coming to cardiovascular disease, we need to think of three things. We need to think of the exposure, which is global warming, the increasing heat, and air pollution, affecting the vulnerable population, which are the older people, and I mean extremes of age actually, and socioeconomic status, and pre-existing health status, all of which leads to cardiovascular disease. So this is the kind of general pathway by which climate change impacts cardiovascular disease. And this is the pathophysiological mechanism. As clinicians, we know that the highest number of heart attacks occur in winter, and now we are seeing more and more heart attacks in summer. And the mechanisms are very easy to understand. For example, in extreme heat, there is dehydration, which results in hemoconcentration, which results in clotting tendency or increased thrombogenicity, which could result in a heart attack or a stroke. On the other hand, when you have a cold weather, there is what we call as peripheral vasoconstriction, because the body tries to protect the heat, because of which the skeletal muscle tone increases, and this results in reduced blood supply to the heart, and again increasing the risk for a heart attack and stroke. Differing ways of having, but ultimately the common end result is the same. So what is our work in this area? I showed yesterday the air pollution model that we have developed. We used a similar approach in terms of developing a temperature model from all the data that are available in the country, using a machine learning technique and looking at an ensemble modeling and creating a developmental database and then validating against the second half of the data, and we created the temperature model, and this is what we had for the years 2008 to 2020. And as you can see, the 2020 looks a little better, probably because of the COVID-induced lockdown or whatever. The temperature was a little lower in that year, but all we are seeing is an rising temperature across the years, mostly in the Indo-Gangetic plain with very high levels of temperature. This picture does not reflect the extremes of cold, but that does also occur in some parts of the country. So this we did for 1 kilometer into 1 kilometer resolution, and now we are working into 100 meter into 100 meter, which I don't think is really important for temperature. For air pollution may be important, but for temperature, even a 1 kilometer grid is important, and we are using 13 easy to obtain daily variables for the entire country, and this has got an overall R square correlation coefficient of almost 0.94, which is excellent. And this is the person who did it from our group. So we looked at two things. Now there are multiple things we looked at, but due to paucity of time, I'm just going to show two things. One is, what is the interaction of air pollution and heat waves in the framework of climate change? So what we looked at is, we looked at heat waves and related it to mortality. How do we define heat waves? There are multiple definitions for heat waves across the country, but the easiest way to define is, if you have 2 consecutive days of high temperature, which is more than the 97th percentile for that location. I was indeed very surprised to see, because we also did it for Shimla. How would you expect a higher mortality in Shimla, where the average temperature is around 30 degrees centigrade in summer? So even there, if there is a heat wave which is defined as higher than what they have usually, suppose from 30 it goes to 33 degrees, the mortality increases, because they are unable to cope up with that sudden increases in temperature. And this is true across all the cities we have evaluated. We did this for 10 cities, and you can see clearly there is an increase in mortality as we go along with an increasing temperature with a heat wave. And the heat wave is defined either as more than the 95th percentile or the 97th percentile for that city. Now, how do we look at the interaction between air pollution and temperature? This is the map of air pollution, that's a map of temperature. It doesn't give you too much because it looks highly homogeneous in terms of air pollution and temperature, except for the southern states where air pollution appears to be lower. So when you look at it, you look at individual association. So we observed that for every 10 microgram per cubic meter increment in PM 2.5, it was associated with a 1.4% increase in daily mortality, and 50% of this mortality, or 40% of this mortality, I would say, is cardiovascular disease. With regard to temperature, we observed that an increase in temperature from the 75th to 99th percentile of city-specific distribution was associated with a 22% increase in daily mortality. So with temperature, it's even more stronger, because any rise in temperature, if you don't have the wherewithal to get acclimatized or respond to that, the mortality rates are likely to be higher. Now let's look at the interaction. This is the interaction figure for air pollution that is modified by the temperature. So when you look at this red line, that it denotes higher levels of air pollution, what the mortality would be. But when it interacts with temperature, when the temperature goes higher, at a given level of air pollution, the mortality would go higher, but with both a high temperature and a higher level of air pollution, the mortality is even higher. And so it increased from a 0.8% change in mortality per 10 microgram per cubic meter increase to almost 4.6%. So that's the kind of interaction we have with temperature and air pollution. This is the relationship of temperature and how it's modified by air pollution. So the percentage mortality, change in mortality and risk due to an increase in temperature from the 75th to 99th city-specific percentile was around 8%. But when daily PM to 2.5, it goes up to almost 63%. So clearly air pollution modifies the effect of temperature. So we need to tackle both in the realm of climate change. Then we looked at hotspots, because it's not static. This is with regard to air pollution. There are several hotspots in the country in terms of air pollution. The reason why I'm showing is I'm just actually taking a cue from what Dr. Beg just mentioned, that you need to look at in a decentralized, localized fashion, because Just the city of Bangalore itself, we showed how there are localized areas of high levels of air pollution. So what we did here was to identify hotspots and temporal patterns of air pollution using spatial analysis. And what we defined here was that consistent hotspot was defined as 8 or more out of 12 years of being a hotspot. An emerging hotspot was defined as 3 or less in the first 6 years, or 4 or more in the second 6 years of being a hotspot. And a declining hotspot is defined as 3 or more in the first 6 years and less than 3 in the second 6 years of being a hotspot. So you would be very surprised, there are several areas in the country which are actually declining, and the reason we have to focus on them is also to learn what did they do differently that we are seeing declining hotspots for air pollution. So consistent hotspot, 10% of the country's area with around 250 million people have a consistent hotspot of high levels of pollution. In terms of the emerging hotspot, 3% of the country's area with 75 million people have an emerging hotspot, and 3% of the country's area with 52 million people are showing a declining trend. And I just wanted to show this particular map because these are three cities, Delhi, Mumbai and Kolkata, which are actually in the news. Mumbai last year was in the news because of the high degree of pollution. But it's important to understand there are specific areas within the city which are really hotspots for air pollution. You might think in a smaller city, air pollution will be evenly distributed, but even within a 1 square kilometer area or a 400 square meter area, you would actually have a very different level of air pollution. And it's all related to the density of the population, probably a slum population, but it also is related to thermal power plants or some other polluting source. So you really need to, though one would do a nationwide study or a statewide study, you need to look at it in a decentralized fashion if you're going to do some interventions in terms of reducing air pollution. The next question that I want to ask is, what about floods? Floods are a big problem in this country, particularly in the northern part of India. In Bihar, for example, in Kerala, Chennai faces floods every year, and that impacts care for people with chronic diseases. So one is it delays the diagnosis of cardiovascular disease complication, and there is a high susceptibility to infections. People with cardiovascular disease or diabetes have a high propensity to die in the face of any infections. For example, influenza deaths is fourfold higher in people with cardiovascular disease. We also saw this in COVID, that the death rates, relative risk for dying, was 3 times higher for those with hypertension, diabetes and coronary artery disease. So clearly infections increase the risk of death. The third thing is treatment gets interrupted because they are unable to reach the hospital or the health system, and therefore if they develop a complication, they are affected immediately. And they are unprotected because it also alters behavioral risk, particularly in terms of diet and physical activity. So flood has a huge impact, which is actually unmeasured. A lot of studies have not been done, and it's being unmeasured. We are playing a small part in a big study which is being conducted in Bihar, where we are looking at redesigning the health system so that the health systems can become resilient and give care. But another area that we can look at is telemedicine. That's an area in which we are intensely working to redesign the health system using telemedicine to reach the underserved. So here we have put in multiple innovations in a simple telemedicine model that includes electronic decision support, point of care devices, a portable echo, AI-enabled ECG, a digital ophthalmoscope, all in one bag, which can be carried by a person or can be used in a brick and mortar model to give care. And the total time taken, including a specialist consultation, could be as low as 1 hour when we use this. And we have shown this to be very beneficial. We are using this in the mobile vans, which can navigate difficult terrains to provide care to people. And we are doing a cluster randomized trial of this telemedicine model in around 150 locations in India. It will begin in March. So this is a preliminary analysis of a pilot study that we conducted in 2 clinics, one in Chennai and another in a place called Pasuvandanai, which is in southern Tamil Nadu. And what we showed is there is a huge cost gain for patients. So this is a possibly a potential solution in the face of extremes of weather where people do not, because 80% of people with chronic disease do not have to visit a doctor. They could actually consult them remotely, and this could be a potential model for addressing the issue of climate change. And this is just an example to show how even at 18 months, the risk factors are so well controlled. This is for blood sugar, where there's a 33 milligram per deciliter reduction in blood sugar, which persists even at 18 months. And this is for hypertension, where there's a 10 by 5 millimeter reduction in blood pressure, which persists till 18 months. So we, with ICMR support, we are looking at a scalable multi-stakeholder and transformative rural healthcare model by establishing a robust rural health research and training platform, for which at a facility, I'll just go to the facility level, where we are looking at climate resilient healthcare facility. Because in the face of a disaster, the last structure that should be standing in a community is the healthcare facility, because that's where the people go. And there are some examples in Wayanad, for example, where people have built hospitals which can actually withstand an earthquake or extremes of flooding and rain. So we need to create that, but also we need to look at some of the things. In fact, it's estimated that world's greenhouse gas emissions, if you calculate what is contributed by the health system, it's around 5%. It's equivalent to the country of France. So simple things like sustainable procurement, waste management, avoiding food wastage, some of these things can reduce greenhouse gas emission and actually result in a change in climate change. What about the impact on droughts? Because climate change can result in droughts, food and food systems. And I mentioned this yesterday. This comes from the famous Dutch hunger cohort, which showed that maternal undernutrition, severe maternal undernutrition, can result in adult onset chronic diseases. It has been shown in several parts of the world, including in India, and this is real. So we need to tackle maternal undernutrition. The good news is the public distribution system in the country is providing food grains to almost 60-70% of the people. So we won't be seeing that extremes of things which we saw earlier, but this is an important area for consideration. The other issue is about sustainable and healthy food systems. So we conducted a study which provides policymakers with a novel interdisciplinary research evidence for how future food systems can deliver nutritious and healthy foods in a sustainable and equitable manner. So we did this in the cities of Sonipat and Visakhapatnam, and also included rural areas, and interviewed 9,000 residents of rural and urban areas. And we used some state-of-art techniques like photo voice and e-cohorts to understand what happens when food is produced at the farm and then gets to the fork. It's called farm to the fork. And what really happens in terms of food diversity, nutrition, food security, and several other areas. I'm not going to present all of that. I'm just going to present something on food wastage, because this has got a huge bearing on water wastage. So let's look at this. So what we did here was we looked at the food sources, weekly household food excess, and food wastage, and water footprint was calculated. So in the step one, we gathered data on 27 food groups, then considered region-wise frequently consumed foods, and calculated water footprint and wastewater footprint added for group-wise percentages, and we calculated the average. So about 1/3 of the people studied, of around 12,000 people, reported food excess. Of these, 20% wasted at least 300 grams of food per week per household, which equated to almost 71 liters of water per household. So food wastage is one of the major sources of water wastage. And only 5% household wasted none, while 75% reused excess food for composting, etc. Notably, most commonly wasted were cooked foods rather than raw foods like legumes and vegetables, thereby contributing to higher green and blue water footprint. And food wastage was higher in the rural areas, and higher proportion of nuclear families, those belonging to the lowest wealth index, not having a refrigerator or farm holdings, and having no helper, reported more food wastage. So this graphically represents the kind of food wastage in these 4 locations, but on an average, we estimated that there was 71 liters of water wasted per week per household, which is a big number. Particularly South India is a water stressed area, and in fact, there's been a huge amount of water depletion. And this is a map which shows, it's a systematic review, and this is a map which shows that fruits and vegetables grown in water stressed areas, it's lower. It's 50% lower in water stressed areas. But more importantly, the nutrient content, for example, beta carotene in fruits is lower in areas where water is depleted. So as a physician, I advise my patients to take more fruits and vegetables, but we also need to look at supply side issues, because we are creating the demand by telling that it's important, but these are supply side issues for which we have to pay attention to. The other area in terms of climate change is industrial scale livestock breeding, which leads to obesity, cardiovascular disease and cancer, but also leads to climate change because of increased production of methane and deforestation, but could lead to food crisis because of grain diversion to the animals and can result in pandemics. So global meat production is estimated to double from 229 million tons in 2009 to 465 million tons in 2050. The IPCC estimated that if everybody became a vegetarian at least once a week, the Earth's temperature will fall by 1 degree centigrade on an average. That's a powerful of what we can do as a group globally. The last thing I wanted to talk about is the intersection of infectious diseases and non-communicable diseases. As climate change happens, we are going to see more and more of pandemics and more of infections. But people with chronic diseases are the ones who are likely to die because of these infections. Studying these together is called syndemics, because when we have the concept of syndemics, we can approach with our mitigation strategies in terms of addressing both. And therefore, it's important for us to identify that there is an interaction between infections and non-communicable diseases and climate change. And this is the biggest bugbear in terms of why people are going to be affected because of climate change and cardiovascular disease. So studying climate change is multidisciplinary. First is we need to get that evidence, and for that we require epidemiological research. Second, if we're going to do mitigation, we need to understand the financial feasibility, so we require health economics research. Third, we need to look at the health systems, because these are the people who are going to give care. And we need people to actually demand that something needs to be done about air pollution and climate change, so you require social sciences research. So for all of this, you require a multidisciplinary or a transdisciplinary approach. We require disruptive innovation, and we need to pay attention to policy and upstream determinants. So to conclude, climate change affects everyone. It affects both the poor, the rich, the young and the old, the urban and the rural population. It's a significant risk factor for cardiovascular disease based on whatever evidences that we have now. There is limited data on direct causation, but smaller studies have actually shown how it increases the risk of cardiovascular diseases. Awareness amongst the healthcare professionals is very low, highlighting the need for integration into medical curricula and patient information. And reforms in public health system are necessary to integrate environmental risk factors and reduce the burden of air pollution, climate change, and other environmental exposures. I am quoting my mentor, Professor Eddy. In one of the talks on climate change, he said, "Never before in human history have we been forewarned on a doomed destiny, but never before in human history have we been so forearmed with the knowledge and tools to alter the course of that history." So I think this is a succinct message as to what we should do. Thank you very much.